Good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable faculty from the USA, Dr. Khan Yagmurlu. Dr. Yagmurlu had a long career in neurosurgery. Currently is a resident in Department of Neurosurgery at CMS Murphy Clinic, University of Tennessee, USA. He was previously a postdoctoral research fellow at the University of Virginia and also Barrow Neurological Institute. He has researched a lot on white matter tracts of the brain as well as on other aspects of neuroanatomy. He has authored and co-authored hundreds of articles in various peer journals, and we are extremely honored to have him today at webinars. And today we'll be talking about surgical approaches to the brainstem. The speaker for the second session is our honorable guest from Japan, Professor Joji Inamas. Dr. Inamas is a chief neurosurgeon at the Saisekai Utsunomiya Hospital, Japan. He is also a visiting professor in the Department of Neurosurgery, Fujita Health University of School Medicine. He did his postdoctoral research fellowship under the Department of Neurosurgery, Stanford University and University of Florida. His clinical interests are focused upon brain tumors and cerebrovascular neurosurgery. He is a noted author with over 150 peer-reviewed articles in distinguished international medical journals. So he is also on the review board for the World Neurosurgery. He has been a recipient of several distinguished awards for his contribution to neurosurgery in his country as well as abroad. We are extremely honored to have him today at our webinars, and today he will be talking about diagnostic pitfalls in brain tumors. Chair for the first session of today's webinar is our honorable faculty from Argentina, Professor Maximiliano Nunes. Dr. Nunes is a consultant neurosurgeon at the Hospital El Cruz, Florencia, Valera, Buenos Aires, Argentina. After his training in neurosurgery, he has completed his rotations in several world-renowned institutions under world-renowned neurosurgeons like Professor Rotten, Professor JFM, and Professor Hugo Stefau. He is an excellent surgeon who specializes in microneurosurgical techniques in the management of complex brain tumors and cerebrovascular diseases. He has received several honors and awards for his outstanding contribution to neurosurgical academics in his country. We are extremely grateful to him for accepting our invitation to chair the session of Professor Khan Yagmurlu. The chair for the second session of today's webinar is our honorable faculty from India, Professor Adil Chagla. Professor Chagla is the professor and head of Department of Neurosurgery at the King Edward's Memorial Hospital, Mumbai, India. He is a vastly experienced neurosurgeon with over more than 30 years in neurosurgery. His clinical interest involves both in the pathologies of brain and spine. He is an invited faculty to several conferences both abroad and in India. He is also a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Joji Inamas. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia and Dr. Ben from Hong Kong are my co-hosts for today. With that introduction, I would like to hand over this online podium to our first chair, Professor Maximiliano Nunes.
Hello. Good to see you again and to be here. It's my pleasure to be part of this meeting to introduce to Dr. Khan Yagmurlu, who is a very good friend of mine. I had the privilege to know him in the last part of my education in Rotterdam. Was one of the most important inspiration to learn fiber dissection. I have a very high admiration for his work, and I had the privilege to know him. He's a very, very kind people, and he gave me one position when I meet with him in the first time. So I am grateful with him, not just for too much I learned from him, also for the friendship. So thank you, Khan. It's my privilege to see you again.
I thank you so much. It's very generous of you, and always great to see you, Dr. Nunes. First of all, I also appreciate for having me here, Dr. Raja, for your kind invitation, and great to be a part of this team. I would like to talk about the surgical approach to the brainstem with the safe antizones, my work about this, the field. So for the brainstem lesions, for surgical planning strategies, we can ask two basic questions to start, the strategy of the brainstem, the surgery. The first question is the lesion is superficial or deep, and the second, the simple question is the lesion is located ventral brainstem or dorsal brainstem. Based on these two simple questions, of course, this is not like that simple, but based on these two questions, gonna give us some idea about what kind of surgical approach we can use. So by saying the superficial and the deep lesions, so superficial lesions, when the lesions, when the lesion comes to the surface of the brainstem, it creates its natural corridor, and basically it can tell us what kind of trajectory, no, excuse me, we are going to use for removal of the lesion. But this is based on this, there's a 2-point method that published. And if you look at this here, can you see my the mouse, by the way?
Yes.
Okay. If you look at this lesion, this is looks like Cavernous malformation, and there's a 2-point method. Basically, the 1 point is placed the center of the lesion, and the second point is placed to where the lesion is closest to the surface. And when we just make a trajectory here with these 2 points, that tell us what trajectory we can use to get this lesion. But sometimes this trajectory can pass through the eloquent, the neurocritical structures like the corticospinal tracts. So in this case, in this situation, we need to combine this method. We want to combine with this method with the safe antizone, the concept. Of course, neither surgeon nor patient are safe when you are in the brainstem. This is how it called, described as a safe before us, like Bricolo and from Italy. That's why we just keep using the same, the concept. But of course, not any surgery in the brainstem is the safe. We could say like less risky, maybe would be more meaningful instead of safe antizones. So to combine this concept for deep-seated lesions, especially because superficial, we already saw it creates its own the trajectory for the lesions. For deep-seated lesions, we don't need to use all this concept, but we want to need some idea. So that's why people describe these two concepts. So we can use this, combine these two concepts to making decision for surgical the approach. On the other hand, anytime the tumor or lesions is going to displace the normal structures in the brainstem, like as we can see here, normally we have the safe antizones between the 5th and the 7th cranial nerves, which is called periotrigeminal safe antizone. But in case of the Cavernous malformation or other tumors, it's going to displace and distort these neurocritical structures. So when we use this here, we're going to cut this STT. STT is not a big deal, but I try to, explain this two concept also is not quite enough themselves. That's why the people also we want to use the mapping if we have a chance to use it. So even like 2% help, the big help. So this is anatomical perspective. We see the cranial nerves from the 1 to 12. And we know except the first and second cranial nerves, all the cranial nerves arises from the brainstem, and the only one cranial nerve arises from the dorsal, the part of the brainstem, which is trochlear nerve, also tenous nerve. The brainstem has 3 parts: midbrain, pons, and medulla, and the behind is the cerebellum. And the vascular supply comes from 2 vertebral arteries come together to form the basilar artery, usually at the level of the pontomedullary junction here. Before the junction, it gives a pica, posterior inferior cerebellar artery, and the basilar artery gives the ICA, anterior inferior cerebellar artery, and the top part is superior cerebellar artery. The rule of 3 described by Dr. Rotten. There's a 3 major parts of the brainstem, and we have 3 parent arteries. The medulla is supplied by the pica, the pons by ICA, and the midbrain the by superior cerebellar artery, SCA, also PCA. The second question was the lesion is located ventral or dorsal. So here's a medial lemniscus that divides the brainstem ventral and the dorsal part. In front of the medial lemniscus, we can say the ventral brainstem. If we are in the midbrain, we can say ventral midbrain. If we are in the pons, we can say the ventral pons. And behind the medial lemniscus is the dorsal brainstem. Also, notable, the medial lemniscus is the most tolerant fiber tract for surgical manipulation. We can pass through the medial lemniscus if the lesion is located in the parts in the brainstem. The neurocritical structures in the ventral brainstem is the corticospinal tract, and the dorsal the brainstem, we see the medial longitudinal fasciculus, which interconnect with the cranial nerves 3, 4, 6, and it provides the eye gaze movements. So we want to keep away of these structures, of course, more, but main structures, neurocritical structures here. So let's see the midbrain, the top of the brainstem. It's a relatively both easy and difficult to reach the midbrain. Now we are looking for the ventral midbrain, the ventral part, and the two key structures is the cranial nerve, oculomotor nerve, and the aqueduct. So we see from front, we see the oculomotor nerves. This is the crus cerebri and the crus cerebri, and here is the the peduncular fossa, and here is the mammillary bodies are the landmarks for the ventral midbrain. We see the oculomotor nerve, 96% passing between the superior cerebellar artery and the posterior cerebellar artery. And what we usually use is, we can use, of course, the base, according to lesion location, we can use a lateral to the oculomotor nerve, cut the midbrain, or we can use in the mid line here, so like this. So this is Dr. Spetzler's technique for interpedicular fossa approach. If the lesion is located ventral, if the lesion is ventral centrally located, we can come from the contralateral side for the straightforward shot and passing through the interpedicular fossa here. So of course there are some perforating arteries going to be here. So there are some samples from his case. This is the lesion here, and then he comes from this way and reach this lesion, Cohen's malformation, and remove it. So the key for this approach is expose the oculomotor nerve, and then if we follow the oculomotor nerve all the way back, we can reach to the midbrain, and if we can see the contralateral oculomotor nerve here, and between the oculomotor nerves in the midbrain is going to be interpedicular fossa. It's kind of sketchy because we don't want to destroy this perforating arteries. I think it's requires some experience. I'm sorry. How can we reach this ventral part of the midbrain? We can come from anterolaterally. Either we can use a terional approach, we can use OZ approach, we can even use the supraorbital eyebrow approach incision. And the one more I can say the lateral supraorbital approach with Dr. Hannesnemi was using it. This is the OZ approach, modified OZ. And here we are on the right side. This is frontal lobe and this is the temporal. And what we see here, the ICA is here. To reach the ventral midbrain, I'm going to follow the oculomotor nerve, find oculomotor nerve, and follow it all the way back and we can reach the ventral midbrain. Either we can cut the lateral to the oculomotor nerve, just lateral to the oculomotor nerve. We don't want to go all the way mid part because the corticospinal tract is going to be here. Or we can follow the oculomotor nerve medially and reach the interpendicular fossa. Another option is mini-OZ approach, and this is the McCarty keyhole. Small craniotomy. It's actually pretty similar with the supraorbital eyebrow, the craniotomy here. Only incision comes from the pterional incision. For the eyebrow incision is gonna be here. So it's dealer's choice. Some people, especially if the patient is a bald, some people they prefer to go to eyebrow, I'm sorry. And if the patient has a hair, you can go this way. So this is the incision, basically, and we see the supraorbital foramen here. We can see the notch. This is the most medial border. We don't want to pass medial the nerve in order to avoid the frontal sinus. And opening this here, and this is endoscopic wave. And again, this is the optic nerves. We see the ICA and the oculomotor nerve is here. If you follow the oculomotor nerve all the way back, we can reach the ventral midbrain. Either medial or lateral incision can be used to reach the central located. So lateral midbrain is, we see the lateral mesencephalic sulcus. When we dissect the internal structures of the midbrain, the lateral mesencephalic sulcus also corresponds to the medial lemniscus in the midbrain. So the ventral is going to be ventral midbrain, and the dorsal is the dorsal midbrain. The critical structure is the corticospinal tract in the ventral midbrain. If you look at the dorsal midbrain, is further subdivided into tegmentum and the tectum. From the medial lemniscus to the aqueduct, it's tegmental. It's called the tegmentum, and has the red nucleus, oculomotor and the trochlear nuclei. And behind the aqueduct is called the tectum. Of course, the tumors is we see the different the characteristic findings in the MRI in the tegmental and the tectal lesions, the tumors especially. The tegmental glioma, the tumors usually has a tendency to go upward or downward, and we usually see the cystic lesions. Also, surprisingly, even like large size tegmental tumors rarely cause the hydrocephalus. But if you see that, we can see the small the size tumor in the tectum, very small size, can cause a patient can come to hydrocephalus because of the compressor aqueduct here. So this is a target area. We can come either from supratentorially and the subtemporal approach. Here's the tentorium. This is the temporal lobe here. And here's the front, and here's the back. We see the lateral mesencephalic sulcus. Usually lateral mesencephalic vein runs and the sulcus. Usually some surgeons just dissected away, some surgeons has coagulated here. So we see the trochlear nerve enters to the tentorium here. Another option, we can come infratentorially, and the lateral supracerebellar infratentorial approach. This is ear, this is top, bottom, transverse, and the sigmoid sinus here. The similar, but upside down. Tentorium, we are in the infratentorial area. This is the pineal gland, and here is the lateral mesencephalic vein. Runs to the lateral mesencephalic sulcus here. Dorsal midbrain, we come from behind, especially the tectal lesions. We see the colliculi. This is surgical cadaveric view, and we see the pineal gland, superior colliculi and inferior colliculi. Target area. We can also either come from supratentorial or infratentorial and supracerebellar. Here's the tentorium here, and we see the superior sagittal sinus and transverse sinus. Either we can come occipital and interhemispheric approach, See the splenium here, and the vein of Galen is here. We can cut the tentorium that provides the greater exposure to the dorsal midbrain, even like cerebellum, and the quadrangular lobule is here. Another option is supracerebellar infatentorial, not the lateral this time. We can use the midline, median, or paramedian. Basically, the incision is made between the midpoint of the distance from the inion to the asterion here. So here is the vermis of the cerebellum. When we do a midline, this is gonna be on the way and it's gonna block your VF to the dorsal midbrain, the paramedian also just, you can just retract to the vermis of the cerebellum and reach to the dorsal midbrain area. Pons, the mid part of the brainstem. Again, the ventral part, in front of the medial lemniscus is going to be ventral. The pons, and the behind is going to be dorsal pons. The critical structures, this is the lateral VF, and here's the front. We see the corticospinal tract is here, and this is this anterior ventral surface of the medial lemniscus here. The key structures for the ventral pons is the trigeminal nerve, and the dorsal pons is the facial colliculus. For the ventral pons, we see the trigeminal nerve, and the entry zones is either supratrigeminal, periotrigeminal between the 5 and 7, and another option is we can use the middle cerebellar peduncle approach. So those are transverse pontine fibers, comes from the cortex in the brain. The same fibers, when they pass lateral to the trigeminal nerve, the level of the trigeminal nerve, is start name the middle cerebellar peduncle. So either depends on the lesion's location. We can use a supratrigeminal incision. We can use a periotrigeminal incision between the 5 and 7, or we can use the middle cerebellar peduncle lateral to the trigeminal nerve. Here again, the trigeminal nerve here, 7th, between the 5 and 7th, above the trigeminal nerve, or we can use lateral to the trigeminal nerve, which is the middle cerebellar peduncle. And this is the target area. Most commonly used the retrosigmoid approach. The incision can be different, like dealer's choice. Can be C-shaped, can be like lazy S shaped, or the vertical incision. Burr hole placement. We see the asterion here is a landmark for this retrosigmoid approach. Once we open, we can see the trigeminal nerve and the 7 and 8. We can just also navigate the lower cranial nerves. And another trick for this middle cerebellar peduncle, this is the petrosal fissure of the cerebellum. It's corresponds like a Sylvian fissure. It's more fragile than Sylvian fissure, but if we just dissect this the petrosal fissure, that gives us more exposure to the middle cerebellar peduncle approach. Again, this is the 5, this is 7 and 8, lateral to the trigeminal. Here we can see middle cerebellar peduncle. Also, it provides the less cerebellar retraction. If you see here, before opening the petrosal fissure, we need to retract the cerebellum more. I mean, it's in the daily practice, maybe doesn't look like there's a big difference, but it can be used. And if you split the petrosal fissure of the cerebellum, we can get more straightforward trajectory to the ventrally located pontine lesions. Here again, this is the medial lemniscus here, and the ventral, in front of the medial lemniscus is the ventral pons, and the behind is the dorsal pons. And also we can see here, this is the petrosal fissure. It's easily opened, and then to reach to the middle cerebellar peduncle. What approach we can use? Again, we can come supratentorially or infratentorially. This is subtemporal and transtentorial. We can cut the tentorium before the entry point of the trochlear nerve in the tentorium. What we see here, this is the trigeminal nerve, and this is the motor, the fibers of the trigeminal nerve. Another option we can use Kawase approach, anterior petrosectomy. Here is the GSPN, which is a landmark, and we can see the arcuate eminence here, and this is the petrous apex. After drill, the petrous apex, we see the trigeminal nerve here, and this is the 7 and 8. And again, the trigeminal nerve is our landmark, so we can either use the supratrigeminal, we can use the pivot-trigeminal between the trigeminal and facial nerve. For this approach, 5, 7. For dorsal pons, this is the floor of the fourth ventricle, which is a little bit more complicated, more crowded here with the structures, according to relatively, the other part of the brainstem. So what we see here, basically, this is the floor of the fourth ventricle. We see the median sulcus, and here's the sulcus limitans. This is the median eminence here, which is important, that I will explain. We see the lateral recess of the fourth ventricle, and superior part is formed by the superior cerebellar peduncle, and inferiorly, we see the inferior cerebellar peduncles are the walls of the fourth ventricle. And in the medullary part, we can see there's a triangles that we want to avoid it. The hypoglossal vagal triangles, trigones, and also we can see the area postrema in the medullary part. And this is the attachment of the telechoroidea. We can see also stria medullaris here. So this part, the medullary part, also looks like the tip of the pen, which is also called calamus scriptorius. So we can use the facial colliculus is the landmark. We can either use a suprafacial approach, which is above the facial colliculus. This is the facial colliculus again, is formed by abducens nucleus and the facial intrapontine fibers. And this is the abducens, the fibers arise from the abducens nerve. Abducens nerve nucleus, nucleus. And this is the facial nerve, after exiting the brainstem, and then we see the fibers. It comes to the facial colliculi, which is located at this part. The suprafacial is bordered by the trochlear nerve above, facial colliculus below, and the medial MLF, medial longitudinal fasciculus. And here's a laterally, if you remember, we have a sulcus limitans here, which is the lateral border. We don't want to pass lateral to sulcus limitans because the central tegmental tract, which is a part of the extrapyramidal system is runs just under the sulcus limitans and the lateral and under the sulcus limitans. What we can see if we cut at this, I mean, it's not 100%, but sometimes we can see the patient has like intentional tremor and then nystagmus because this is a part of the extrapyramidal system. It's the same thing. Sometimes you can remove the olive in the medulla and no symptoms post-op, but some patient can have like the extrapyramidal system symptoms. So it's not 100%. It's not like a corticospinal tract that we know if we destroy the corticospinal tract, there's going to be injury and post-op deficits. But the central tegmental tract is kind of surprised. If you cut it, it can cause some, the extrapyramidal system, the findings here. And the landmark for the central tegmental tract is going to be sulcus limitans on the surface of the brainstem. So that's why we want to use called the sulcus, the median eminence here. We want to use this part. Another landmark, actually, here is a superior fovea. We can see it's kind of like triangle. Usually, the top of the facial colliculus corresponds to the top of this triangle. So, I mean, if you have a chance, we should use the map, of course, because all the structure is going to be distorted. But the anatomical landmark is the most upper border of the facial colliculus is going to be the top of the triangle of superior fovea. So for our paper with Dr. Walton, this is the first paper with the description of the superior and inferior facial the approaches. It says this is the superior cerebellar peduncle is the lateral border. Based on anatomy, we just noted the lateral border should be sulcus limitans instead of superior cerebellar peduncle here to preserve the central tegmental tract. Infrafacial approach, facial colliculus, we see the hypoglossal trigone. Inferiorly and medially, we can see MLF, and those, those structures are the border. Here we see, this is also, the first description, and it actually says the inferior border is a stria medullaris, but there are a lot of variation about this stria medullaris to recognize during the surgery, so we change it because correspond to similar area. This is a telechoroidea attachment, you can see here. For the infrafacial colliculus and inferior border of this approach, it can just select it with the attachment of the telechoroidea inferiorly. And here's the lateral recess. We can see during the surgery, when we open here, we can see this is the attachment here. And those are the inferior borders, the level of the infrafacial approach. We don't want to go under below this level to preserve the hypoglossal and the vagal triangles here. Again here, so once we open the telechoroidea televelar approach, we can still see the attachment, and this is the inferior border of the infrafacial approach is gonna be attachment of the level of the attachment of the telechoroidea. Of course, this is the target area, the floor of the fourth ventricle. We can use the midline suboccipital approach and the televelar approach. We see the tonsils here, and this is uvula, and the section and opening televelar approach that provides us the exposure of the fourth ventricle, and we can see the facial colliculus again. Here's a superior fovea, and this is the top of the triangle, and like this placement. And facial colliculus, usually 66% of the cadavers are visible. That other, the rest of the 34% is not visible. So the superior fovea triangle can be also used as a landmark for the facial colliculus. The last part of the brainstem is the medulla. Olive is the structures, key structures in the medulla. There are a bunch of the salt sulci that we use for removal of the lesions. How can we get this part? Far lateral approach. Again, the skin incision is the dealer's choice. This is the far lateral approach. We can see the vertebral artery and C1. We are on the left side. Ear is here. So removal of the far lateral, basically, and define the olive. We see we can use a post-oliveral sulcus here, just behind the olive. Again, another option is like removal of the olive. So it can be, there are a couple of the publications, especially Dr. Evandro Oliveira has the paper about it, trans-oliveira approach, to remove the olive and then reach. But you never know, the patient can have like extrapyramidal system, the deficits post-op period. We can use the the sulcus behind the olive, post-olivated sulcus. We can use the anterolateral part in front of the olive between the hypoglossal nerves fibers and the C1. And the last one is the dorsal medulla. We have posterior median, posterolateral, and another sulci in the dorsal part of the medulla that can be used to reach the deep-seated lesions. If the lesion comes to the surface, it's like we already know the trajectory. And recap is the midbrain. The key structures are the oculomotor nerve, aqueduct, for the pons, trigeminal nerve, facial colliculus, and medulla is the olive. Before I finish, I just want to show the Rotten collection. Is that everyone can have the free account, and Dr. Rotten, thousands of the pictures of Dr. Rotten is the fellow. It's stored here. It can be used as educational material or this is CCA4 and copyright issues, like you guys, anyone can also use as their own the lecture stuff. And the last thing is this is the illustrations, like drawing illustrations from this the atlas and the brainstem surgery for further the information that the book also can be used. Again, thank you so much. That's all what I would like to talk about this brainstem issues. And please, if you have any question or contribution.
Fantastic talk, Kang, like always. I have some questions for your expertise, like to learn from about you. What is your opinion about the intercollicular? I mean, in the tectum, in the quadrigeminal plate, the approach, supracollicular or infracollicular, you described, we learned about that. And in some point, my question is, what is about the middle line? Because we have the aqueduct behind, and I remember you talk in some moment about we must be worried about that election. I keep in my mind that because some people describe that approach for the middle line, but I remember you in Jacksonville one time and you say you must be careful, not just for the aqueduct or the obstruction, just because we have the reticular formation that there. And so I keep in my mind that, but some people insist in some point that approach can be useful. Of course, when the one cavernoma, for example, have one expression to the dorsal point of view, but I mean, maybe we need to push a little bit more to reach some more safety approach in order to keep very safe the aqueduct and the reticular formation. That is my question. No, my question is, what is your expertise opinion about this? Is we must be find another approach to be a little bit far away to the election of the middle line. What is your opinion about that?
Yeah, I agree with you. Actually, intercollicular area also is being using as a safe zone. The thing is, we always to talk about based on the normal anatomy, and also as you said, if there's a lesion over there, there's a very small room over there. If there's a glioma or something, there is gonna be like most likely is gonna come to the surface, and no matter where you're gonna use it, even either supracollicular, infracollicular, intercollicular approach. So, but if you think about the normal anatomy, is a lot of the neurocortical structures around, but of course the lesion is gonna make its own, the room, the space over there, and then we can use it, and it's been using intercollicular too. The aqueduct is, again, just as we talked before, just the verusam, because just in front of the aqueduct also is like has an oculomotor and the trochlear nuclei in the midline. So that's that we need to keep in mind. Also, periventricular, the reticular formation is gonna be there, and but some functional neurosurgery, they also destroy the periventricular, the reticular formation for pain or for other kind of like problems. The finally, I would say, yeah, the tumor based on anatomy, we say something, but if you like go to OR and just in the daily practice, we can see something different. But again, just I agree with you. The intercurricular, the zone is also can be used because the tumor is going to be blown over there. Just going to be can be used unless the passing the front in front of the aqueduct.
Thank you. I keep always in my mind when I follow you, I see your expert in opinion, and when we see your anatomy dissection is spectacular, like always. But you teach to the others about the anatomy, the theory of the 2 points. But today, for example, you explain to us. You put one example, one cavernoma pushing the fibers of the spinothalamic tract, and in the front I remember one picture, I remember the corticospinal tract, and you teach to us the combination between the anatomy, the theory of the 2 points, but the safe entry zone. We keep in our mind about that. We think about, but most of the people think the safe entry zone is just anatomy, but you teach to the rest of the people about to think in how can we need to be in the interpretation of the normal anatomy and for example, the damage of the one cavernoma or the tumor in the human being, because we show to us that pathology, that disease can be pushed some structure, and our interpretation, we can, in that way, we can choose another pathway in order to reach the cavernoma, for example. So the variation of this concept is crucial, in my opinion, to change some point of view and some entry zone. Maybe a little bit far away entry zone can be more useful if you compare with the normal anatomy, because the safe entry points can be combined with the adaptation of the MRI. I mean, to keep this concept in our mind, in my interpretation, you must know where is the normal position of the tract, for example, and how can be pushed for the pathology in order to reach maybe another point of view. So that is the point more useful for me. I learned from you about that. So I keep in my mind that concept, not just like a box, just anatomy, just 2 points theory. The combination of both is the more useful concept I keep in this talk.
Yeah, I totally agree with you. We got to think like case-based. Again, the technology also, to help us, but we know that not all countries, all the world has some technology. If you don't have, we need to map like safe entry zones, and also if you have a chance, the mapping helps a lot especially for the cranial nerves in the brainstem. Some people use the DTI, pure DTI. Yes. I don't know it's not adopted very well in the brainstem, the DTI. Just I think the brain has more helpful, but the brainstem is because of very dense structures, and it's with the fiber structure you already know very well. But I think the mapping is the gold for that kind of in the distortion of but all the time we need to map. We always need to keep our mind as a safe entry zones and 2-point method too. But sometimes the lesion can come to the fourth ventricle, like a superficial. But if it's located at the facial colliculus, sometimes you gotta go middle cerebellar peduncle instead of like shortest. The safe entry zone doesn't mean like shortest route. Sometimes you have to turn that way.
You're right. Yeah, you're right. When you describe the supracollicular approach in the foreventricular floor, for example, you talk about the central tegmental tract. Not many people know about the central tegmental tract. What is the implication? Even if you push a little bit in the corner of the superior peduncle, we push the colical foot nucleus, and we can be some problems in the heartbeat inside in the surgery, for example. But that can be a very good safe entry point just for anatomy. But if not, in the real life, we can approach transpeduncular, transmiddle peduncular, like you say, and we can preserve the dorsal portion of the foreventricular floor. So that adaptation, in my opinion, you teach to us is the most important concept in this talk, in my opinion.
Yeah, thank you so much. It's very kind of you also. You just give the compliment. So just I'm so happy to make a contribution to the literature, and also I'm just learning from you too. You're just doing a great contribution about this brainstem area. It makes people like to more curious about it, and then more people start working it. We get our knowledges more and better.
Yes. Thank you, Cam, for your words. Thank you.
I appreciate that. Thanks.
Thank you very much, both Professor Dr. Khan and Max, for this wonderful session about brainstem. Professor Adil Chakla, would you like to ask something to Dr. Khan?
Yeah, I would love to. In fact, can you hear me?
Yes, sir. Yes.
Yeah. So, with little or very, let's say, meager technological use, I think I would love to use the clinical picture of the patient. For example, if the patient has a third nerve, or a patient has a sixth nerve or a seventh nerve, and the history, which would also tell me which came first and which came second. So it would tell you where the tumor came and how it's expanded through the brainstem. So the clinical presentation of the patient is very vital for my approach to these lesions in the brainstem. It'll also tell you how aggressive the tumor is. So a lot of history, just as we're going to talk about pitfalls of the diagnosis of tumors, which starts again with the history of the patient. So I always like to have the patient beside me, or a good history of the patient and a good clinical examination of the patient while I look at the MRI and all the other gadgetry that we have when we describe tumors in the brainstem. I'd like your comments. Thank you.
Thank you very much. I'd like to thank both the speaker and chair for this time and support for the ACNS webinars. I'd like to mention that Professor Shubin has updated that there are around 750 people who have logged in on YouTube, WeChat and Zoom. So we are extremely grateful to him for broadcasting this in China as well. So if there are no further questions, we can move on to the second session. And first we will check with Professor Inamas whether his mic is working. Professor Inamas?
Yes.
Okay. Fine.
Well, good morning, good afternoon, good evening to everybody again. And it's great to have Dr. Inamasu back with not only his image, but also his voice. So I'd just like to say that we're going to talk about pitfalls in the diagnosis of brain tumors. Again, I'd like to stress on the fact that you have a whole history and examination which each neurosurgeon should spend time with, because that's the beginning of the case. And then, of course, we go on to all the new advances in imaging, and also then frozen sections and different diagnosis at the time of surgery as well. From here, I'd like Professor Inamasu to take over and to share his ideas and comments. Thank you.
Thank you for the introduction. Thank you, Dr. Kato, for introducing me to the audience. And let me start the lecture. So I'm not a brain tumor specialist, but I'm an expert on a neurosurgical emergency. So my talk is about the brain tumor diagnosis in terms of neurosurgical emergency. And I present many cases with a misdiagnosis or delayed diagnosis. So let's learn together from errors and mistakes, okay? And about the pitfall in the brain tumor diagnosis, there's two mistakes. The one is the tumor is suspected, but actually it's not a tumor. So they call it tumor mimics. And the second, when tumor is not suspected, actually it came to known as a tumor. So they call it chameleons. And there are some people made a very good review about the brain tumor mimics and chameleons. So please see these papers. And first, I present some cases where tumor mimics. So this is a cases with the 75 lady with the schizophrenia. So she presented with the polydipsia and the hyponatremia. So we suspect the from the brain CAT scan. So there is the apparently cellular mass, and the patient has a hyponatremia, and we suspect the patient may have a craniopharyngioma, and but actually the MRI shows the this is the T2 sagittal scan, and there is the apparently phloboid there, and the correct diagnosis is the naturally the brain aneurysm. So because of the classification of the aneurysm, it was the first considered as the craniopharyngioma. So although the aneurysm rarely have a classification, so it occasionally have the such finding. So please take care of that. And this is the we thought this is a patient with the young male presenting with the worsening the hemiparesis, and this is the solitary lesion. So we suspect the patient may have a thalamic glioma, and the biopsy was performed, which proved to be not the tumor, but the multiple sclerosis, the tumefactive type. So we have to be careful about the tumefactive multiple sclerosis because it becomes very large and looks like a tumor. Then, although the lesion disappeared after the steroid therapy, so it reappears like this. So it reappears in other locations. So it is not very curative, actually. And we have to be careful about the multiple sclerosis because it became positive with the intraoperative 5-ALA fluorescence. So this is cases with the misdiagnosis, and this you can see the looks like a tumor, but actually the pathological diagnosis shows it is not the tumor but the inflammation. And because the 5-ALA, the lymphocyte is activated, and it shows the 5-ALA false positive findings. So we have to be careful about that. And similarly, there is some report on cerebral infarction mimicking high-grade glioma. So even a cerebral infarction may have 5-ALA positive findings. So this is the cases with the cerebral infarction, which was misdiagnosed as the glioma because of the 5-ALA positivity. So regarding the 5-ALA, the examination, so we have to be careful because both false positive and false negative may occur. So then we move on to the chameleons. Chameleon is it does not look like a tumor, but actually found out to be tumor. So this is our cases. This is the cases with the 75-old gentleman who came to us after a fall, and apparently the left slide shows the subdural hematoma, and we performed the hematoma evacuation, and the hematoma mostly disappeared. But after the 2 months, the gentleman came back with the worsening symptoms, and we noticed that there is the skull erosion there in the right picture. But actually the skull erosion has already been there in the first slide. So we should have take notice about that, and we have a second surgery, and we put the sample to the pathological lab, and the pathological findings show it's a very tumorous lesion with the vascular conformation, and the diagnosis of this patient was angiosarcoma of the skull. So this is the bone scintigraphy showing the strong accumulation of the over the skull, and also a spine. And we published several years ago, and lesson learned from here is the skull is the location where various sarcomas, angiosarcoma or myosarcoma or osteosarcoma may originate. And this is the apparently, this is the subarachnoid hemorrhage. This patient is a 35-year-old lady presenting with the loss of consciousness, and CT angiography shows looks like there's no aneurysm, but anyway, we have performed the exploratory surgery to look for the aneurysm, but there is no aneurysm there, and we encounter some abnormal tissue during the surgery, and we take the sample for a pathological diagnosis. Then after the surgery, we put the patient to the brain MRI, and the brain MRI with the gadolinium shows there's the enhancing mass in the pituitary lesion, and the lab examination shows this is the undifferentiated sarcoma, very aggressive type, and unfortunately, the patient as the right picture shows, there is the patient developed the cerebral infarction because of the vasospasm and passed away, unfortunately. So we published this in another paper, and also there are several papers reporting that the pituitary apoplexy can mimic subarachnoid hemorrhage, both clinically and radiologically. And this is another untypical pituitary adenoma cases. This is a patient who presented with the hemiparesis, and the MRI shows the apparently the cerebral infarction. But actually, the cause of the cerebral infarction was something like this: the large pituitary adenoma encasing the middle cerebral artery. So we should know the pituitary adenoma rarely causes the cerebral infarction like this. So there is the other papers reporting the event like this. And intravascular lymphoma is very famous for causing the multiple cerebral infarction. And this is a paper from from Germany or from Switzerland, reporting there are multiple small infarctions, and actually pathologically it was the intravascular lymphoma. There are many papers reporting the intravascular lymphoma causing the cerebral infarction. Our case is a little bit different, but the cases, this is our recent cases. The patient came to us with the hemiparesis, and apparently the diffusion image shows the looks like a lacuna infarction, and the patient was treated as a lacuna infarction. But the 2 months later, despite the treatment, the lesion seemed to be enlarged, and another 2 weeks later, the lesion developed much further. So the patient was referred to us, and biopsy shows the primary CNS lymphoma. This is the patient, looks like a putaminal hemorrhage, and we have a surgery, the hematoma removal for this patient, and the in the right slide, the hematoma was removed nicely, and the patient was sent to a rehab hospital, and in a good condition. But unfortunately, the patient was sent back to us 2 months later with such a growing mass. So this is actually glioblastoma masquerading as a hypertensive putaminal hemorrhage. So we published several years ago. And this is the other cases. Also, it looks like a brain hemorrhage. And also, we remove the hemorrhage, and in the CT CAT scan, it looks like very good in the image C. But the patient was sent to a rehab hospital, but the also sent back to us. Looks like there's the growing tumor on the left side. So glioma mimicking the ICH is actually not very rare. So there is several papers reporting the glioblastoma mimicking the ICH. So when we see the intracerebral hematoma, so we have to be careful, because it may be actually glioma cases. So this is the another paper. It came from a pediatric population, and also even in the pediatric population, the something case like this exists. And this is a cases which looks which came as a trauma cases, and it quite looked like a brain contusion in the left picture, and several weeks later, the contusion was resolved, and it looks like a very natural causes. But actually several months later, so the patient came back with such a finding like this. So this is very unfortunate. And this is a cases with it looks like from the location, it arises from the looks like quite the cavernous hemangioma, and the patient presented with the seizure. It's the typical location for cavernous hemangioma. So patient was treated by anti-epileptics, but several months later, the patient came back with the enlarging mass and looks like it. So we have to, so when we see the lesion in here in the hippocampus, so we consider it as the cavernous hemangioma, but the patient should be monitored closely because cases like this also exist. This is the another cases which was the presented with the also seizure and the lesion in the temporal tip lobe was considered as the typical herpes encephalitis, and the patient for some reason recovered with the aciclovir and also course observed. But however, the 3 months later, the patient came back with the such a growing mass glioblastoma. So lesson learned here is the ICH should be monitored closely in the subacute or chronic phase with imaging. And when we perform the hematoma location, sometimes the sampling of the hematoma cavity to the pathological lab may be helpful. So this is the our cases, not the misdiagnosis, but the mismanagement in the timing of surgery. So this is the cases which present to the looks like ICH, but because of the enhanced CT enhancement, we made a diagnosis with the hemorrhagic brain tumor, and because the patient only has a headache, so a patient was scheduled to have a biopsy 1 week later. But however, before the day of the biopsy, the patient had the deterioration because of the rebleeding from tumor. So when lesson learned here from this case, so that we publish this in another paper, and lesson learned here is for glioma presenting with the hemorrhage, the surgery should be performed quasi-emergently. And also spinal hemorrhage may also be caused by a tumor. We should know about this. So this looks like a spontaneous spinal hematoma, but actually it was caused by a ependymoma bleeding. So there is some paper reporting the spinal bleeding from the spinal ependymoma. And there's some paper reporting that the reversible posterior leukoencephalopathy, RPLP, looks like a glioma. So this is a case. This picture is a cases. It looks like the tumor, but actually it was the lesion disappeared after the steroid therapy. So this is the cases with the leukoencephalopathy mimicking glioma. But actually, on the other hand, the glioma may mimic leukoencephalopathies. So this is the our cases. So this is the cases with the previous lymphoma treated by methotrexate, and the patient have a white matter lesion, and the patient was considered to have a methotrexate-related leukoencephalopathies, and the white matter lesion progressed like this, and but the lesion was not responsible responsive to steroids. So it was untypical for the methotrexate white matter lesion. So the patient was sent to us for a biopsy. And actually, it was the white matter, looks like white matter lesion, was actually a grade 3 astrocytoma. The lesions shrunk after treatment with temozolomide. So we published several years ago for this in this case. And this is the another case. The patient presented with the seizure, and the patient looks like a white matter lesion. But for some reason, the white matter region disappears, not completely, but the most of the white matter lesion disappeared. So the patient was course observed, but the 6 months later, the white matter lesion came back and worsening condition, and the biopsy showed the actually it was the lymphomatosis. So there's some special name called for this for this disease, lymphomatosis cerebri. And there are some papers reporting this condition, lymphomatosis cerebri, and it was a very untypical white matter lesion that progresses very rapidly. So this is the another cases. The white matter distribution of the white matter lesion is very untypical, and the lesion progress very rapidly. So we should, when we see the white matter lesion, we have to know about the this lymphomatosis. There's paper reporting this condition. So lesson learned here is the multiple sclerosis and other leukoencephalopathies may mimic gliomas, and glioma may, on the other hand, glioma may mimic multiple sclerosis or leukoencephalopathies. And also, we have to consider about the lymphomatosis cerebri. And actually, they are not mutually exclusive, and they may coexist. So a very famous condition is the bevacizumab-induced reversible posterior leukoencephalopathy. So in a patient with glioblastoma treated with the bevacizumab, so this white matter lesion may develop. So there's some cases which glioblastoma cases which have bevacizumab related RPLS. And when we see lesion like this, so we may differential diagnosis is this may be glioblastoma, or this may be a brain abscess, but actually GBM and the abscess coexist. So not the glioblastoma or abscess, but the actually glioblastoma and abscess is the possible. So this is the cases with the glioma coexistent with the brain abscesses. So we should know these two may not be mutually exclusive, and they actually coexist. And the steroids and immunosuppressants are risk factors. And more complicated, the glioma may arise after treatment of brain abscess. There are some glioblastoma cases which arise after treatment of the brain abscess. So there are some cases with the glioblastoma which arises after treatment of brain abscess. And So this is the final slide, and various cases are presented to see how the misdiagnosis happened and what type of the misdiagnosis occurs in the diagnosis of the brain tumor. And thank you very much.
Thank you, Dr. Inamasu. It just humbles us as neurosurgeons to know that there's so much that can happen and there's so much that we need to do for us to be what we are as neurosurgeons today. What's really relevant is that you've taken all the pains to check on so many conditions that either appear to be tumors and they're not, and vice versa. It also humbles us that we take so much for granted. So it's extremely important that we learn to respect that, learn to keep our eyes open, ears open. We keep on following up our patients. A simple case of a hematoma. How many of us send the hematoma for histopathology? How many of us follow up with regular scans? And how many of us would do an MRI as well as a CT scan for a simple hematoma? So your talk has given us a thought to ask ourselves these questions and to investigate our patients thoroughly before we even attempt surgical evacuation or surgical excision. I think what is more relevant is if there is a medical condition and we need to then do something which was absolutely unindicated. I think that makes it even worse. So it's very relevant that we investigate our patients to the full. It's also important to have these various landmark papers that we've read to educate us on to which are the possibilities that we might encounter when we're dealing with conditions, especially tumor mimics. And also, very important is to follow up the clinical history of our patients, which would tell us. For example, you have metastatic choriocarcinomas in a young patient presenting with a bleed, often missed, and then we realized that we could have done a relevant treatment plan for this young woman. There are so many conditions that we will still come across in spite of this lovely lecture that you've given us, which will again make us open our eyes. With this, I think I will hand over the mic back to Raja. And if there are any questions about this wonderful topic, please. Thank you.
Thank you very much, Professor Adil Chagla and Professor Inamasu for this wonderful session. We have Ben who has raised his hand. Yes, Ben.
Yes, thank you so much, Professor Inamasu, for this lecture. I would like to echo with your idea that we, as a neurosurgeon, we need to be aware of this rare condition because it will affect our treatment of the patients very differently. So I agree that I do not have any particular question, but I have some comments about some important things we need to be aware of as a young neurosurgeon. One thing, as mentioned by our chair, Professor Chaga, is choriocarcinoma. It's a thing that we must remember in young patients presented with ICH. Those cases will cause those small aneurysms and causing those features. Another things that we need to bear in mind is a TB as infection, which cause tumor mix. And also for young patients with ICH, sometimes encounter those with leukemia, acute leukemia presenting with ICH or SH. And also another quite interesting disease is the IgG4 disease that we occasionally encounter with, for example, with tumorous lesion or dural enhancements that we need to consult our medical colleagues to help to handle this. So, I would like to thank you so much for Professor Inamasu for sharing us his He's very experienced to share his experience on these cases, and it helped us to open our eyes a lot. Thank you so much, Professor.
Thank you, Ben. Yes, Max, would you like to ask something?
No, I agree, and I keep with the last word about the professor. We must keep with the eyes or eyes open to put the balance between what is, for example, one imaging we think is a tumor, but maybe if not, and the develop of this imaging can be very be important to put in the balance between one diagnosis and another. We must keep open our mind in the moment to for the diagnosis of the and take one treatment for the patient. I mean.
Understood. Thank you very much. So I think we have come to the end of this webinar, and I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Dr. Khan Yagmullu and Professor Joji Namash, and the chairs, Professor Adil Chagla and Professor Maximiliano Nunes, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and as I mentioned, there are around 750 people who have logged in live on YouTube, WeChat and Zoom. A special thanks to my co-host Dr. Libun Singh from Malaysia and Dr. Ben from Hong Kong who have joined me. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.